Good afternoon, everybody. Thanks to the organizers for inviting me for this debate. My talk is on the role of surgery in case of early NSCLC. So, role of radiotherapy. We don't have emotion in our session because nobody believes the surgery is the ultimate one. So, what is motion? Motion is nothing but illusion. So, everybody believes that. So, now coming to the myth, as Dr. Nijamuddin says, as philosophy says, myth is where science does not explain anything. So, according to Greek people, myth was that Apollo chases the sun and sun rises. So, my colleague believes that I'm the only hope, but things are not true because radiotherapy is the myth buster. Because radiotherapy should be the new associate for early lung cancer. Why it is so? Because there is shifting conversion from myth to reality, based on biology, based on evidence, and based on technology. Coming to a little bit of SBRT. SBRT is nothing but a high dose radiation, precise one. And if you think about biology, it's biologically more than equivalent dose is much higher than conventional radiotherapy, and it has been proved that over the conventional radiotherapy, it has a good amount of local control rate and survival that is nearly comparable to surgery. Now, these are schedules, I'm not going over this. And these are the current guidelines, as Dr. Nijamuddin said, that early NSCLC, medically operable, yes, surgery, this guideline says so, and inoperable rules for RT. Now, currently, the role of RT is only for inoperable NSCLC, high risk for surgery, and who decline surgery. And these are the criteria, and Nijamuddin also said, so I'm the time constraint, I'm going with this. Now, if you think of inoperable early NSCLC SMPR data, these are early ones. So these data says stage 1 NSCLC overall survival 5 years around 55% and 7 years around 47%. This is comparable to surgery data, and Dr. Nijamuddin can argue that this is before that surgically, like mediastinal lymph node sampling data also. Now, surgery, the issues with surgery, significant variation in surgical outcome based on the settings and caseload of the institute. Yes, this is a complex surgery, so this high volume changes are needed. And the model data as available previously was 90 days model 5.4 and 7.8% non-teaching hospitals, and complications around 9%. Overall survival data still is comparable to the early NSCLC data, which are available for SCPR, medically inoperable. But the surgery, if we go analyze the data, it shows that the risks are associated with the mortality and morbidity risk associated with cardiovascular and age-related factors, which are not discussed in our previous talk. So, if you think of early operable NSCLC, ST1 lesions, they are two types of surgeries they usually do: lobar resections, sublobar resections. If we dig into the data of sublobar resections, basically these are the candidates which are misguided one. They should be come into radiation oncology department because sublobar resections have much of higher local recurrence rate. And if you think of RCTs, yes, the true fact is RCTs comparing SMPR versus lobectomy or MNDs is not available. These are the poor approval, they are stopped, closure stars and Startooth. So, and the non-randomized evidences get available are like, if we compare in different trials, the 5-year overall survival for SMPR is 78%, the Japan study, and 3 years 79%, though not randomized one. And if you think of the small analysis, it only available for comparing the SMPR data with surgery is the pooled analysis of SARS and Rosal. These are available in the 2015, and this has a better tolerated and better overall survival, rigorously survival if we pull the data from these two trials, the SMPR arms. And the only study available comparing SMPR, because why these studies are not available, because SMPR is quite new technique in surgery, so the data needs to be give some time to mature for RCTs, and I'm coming to the details later on. And now long-term results of STARS SMPR pooled analysis data are comparing with the VATS and other comparative studies. And if we react to the SMPR data 80 patients were actually compared to the other data from VATS. They have propensity match analysis shows that these are non-inferiority kind of results coming into play for SFBR in comparing with VATS with MLMD. Now, if quality of life issues, yes, the RT, if you compare the RT PFT data versus the surgery PFT data versus SFBR PFT data, this is a significant drop in surgery PFT before that. And if we compare with quality of life, yes, SFBR is a bit of a higher amount of quality of life, global quality of life index is quite better one. Now, surgeon can say that central located tumors are much higher risk for like SFBR, but these data is shows that SFBR can be safely given to the central located tumors, though the doses are less in comparison to peripheral located tumors. But it has the outcomes are comparable with if you compare peripheral located tumors SFBR versus central located tumor SFBR over 4 years of follow-up data. Now, ongoing RCTs can be compared. If me and Dr. Nizam comes into this conference 5 years later on, we can debate much more with these data available, 7x and Valor. Now, my question to audience and Dr. Nizam also, does patient preference exist? Because if patient comes to the MDT and automatically surgeon says that this is our case, so this is a T1 tumor, so send the case to us and we'll do the operate. But just to give an example of what happened to the SFBR tooth data, the SFBR tooth study, they have actually separately analyzed this peripheral located tumors plus SFBR with surgery, and the interesting the subset analysis was that 41% patients were actually why did the study fail? Because 41% patient randomized to surgery actually declined to go for surgery. They opted for SFBR. This is the hardcore reality. We have to accept that. And if we keep the patient and patient family members to have a discussion with surgeons and radiation oncology colleague and to decide upon what is what. So then you can go for the RCT and compare the data, and after 5 years you can see, you can actually analyze this, about the comparison. Now, if you dig into the data much more in the retrospective data, you can see that actually the SFBR population was quite biased because the medically inoperable patients were opted for SFBR. So from the beginning, the data has a confounding bias factor. And yes, definitely there are certain true N0 patients who are actually stage migrated and intent to analysis data was missing. So now a little bit of technology about how SFBR developed, because SFBR is new technology one, is coming into play for the last 5 to 6 years. So we have a much more precision, we have much more cost effectiveness in case of SFBR, because the toxicities and mortalities are quite fewer one currently, because we can address the lung motion in different technologies. There are different motion management systems available in market now and actually using by the different vendors. So we can have much more precision and control over the toxicities. And for the future, like biology, why I'm saying that this debate should be again repeated in 5 years later on, because currently immunotherapy has a role to play with SFBR, because immunotherapy changes the biology a bit and it also plays a role with the particle therapy. So these are ongoing trials which can actually dig into this biology factor, and coming up later on we can have a nice data on like immunotherapy combining with SFBR and exploring the microenvironment of the tumors. So now talking about the limitations, as Dr. Nijamuddin said, that nodal staging SFBR is absent, but you can have a PET-based and EBUS analysis, and the data he actually compared are not actually PET stage patients. So if we have a PET stage patients, we can also have like N0 patients with clinically which are comparable with the mediastinal sampling data. So for the MDT, if patient comes with the MDT, and they should offer two gates. One is an invasive one is a high risk of hospital stays and surgical mortality, and one is a non-invasive one is daycare procedure with zero mortality rate. And the choice should be given to the patient. Thank you.
Thank you, Dr. Kazi, for that lightning talk on SAVR for early lung cancers. Would Dr. Nizamuddin like to come for rebuttal for new chance? Yes.
Look, Kazi has put the facts well. There are some challenges in surgery also. Like he said the sublobar resections are inferior. But later, recent trials showed sublobar resections, if done well, segmentectomy with the lymph nodes, process and confirmation of lymph node negativity gives excellent results. But having said that, there are challenges. The segmentectomy is a very skilled procedure, and those who are skilled enough to do wax segmentectomy will be very less, especially in our nation. So the capacity building is very important, and I think both techniques are here to stay, SABR and surgery, and we should be focusing on capacity building in both areas. SABR also the availability of expertise is very less. So both the techniques will stay, and both have their own merits. Thank you.